Ladies and gentlemen, good evening. Welcome to yet another edition of the Lamboms Show. Our regular Wednesday slot today is kind of an interesting one. We're beginning a series of conversations on mental health. July is celebrated throughout the United States as Minority Mental Health Awareness Month. Unfortunately, we are getting to these 21 days into the month. And we just want to get into, look at different things. And I'm starting off from a very, very strange place. I'm starting off looking at DC, the District of Columbia. That is where I work. And we want to look at the mental health within the district, the mental health system. The topic for today is navigating the mental health business, mental health space within the District of Columbia. And we could not have a better person to navigate this space with us than Mark Levota. I want to thank Mark for coming on. Mark is the Executive Director of the DC Behavioral Health Association. We're going to hear a lot about that. And Mark, thank you very much for coming on.
Hi, thanks for having me.
Yeah, so give us a little bit of background, what you were coming from, what you do, what your regular activities are.
Yeah, sure. So the District of Columbia Behavioral Health Association brings together organizations that provide mental health or substance use disorder services and provides them the opportunity to collaborate in their work on behalf of district residents. We have three major activity areas. We do policy advocacy, where we work with the DC Council and staff at the council offices, as well as with the executive, with the mayor, and with district government agencies, and talk to them about how DC regulations, laws, and policies have effects on the behavioral health provider network and ultimately on people who receive those services, and try to make sure that we develop a system in the district that advances high quality whole person care. We also provide training and technical assistance opportunities for our members. Organizations that belong to the association become members of the National Council for Mental Well-Being, and so they have access to all of those national resources, and then I'm their face in the community. And so I get the opportunity to have conversations with people in the community, talk about their experience with mental illness, substance use disorders, emotional distress, trauma, the other things that might bring them in contact with a mental health or a substance use treatment program, or that might make them interested in learning more about what those services are. So that's a little about what we do.
So thank you, Mark. And I want, for the sake of full disclosure, to say that I am currently working in a mental health agency in DC. And that is how I got to know Mark, because we have a weekly meeting with the director of DBH. DBH is Department of Behavioral Health. There's a weekly Thursday meeting, and before it used to be a monthly meeting where we actually went down there. We are grateful that it's weekly now. But Mark, so that's great. Policy, executive, and all that. We find that, what are some of the main challenges you're seeing within the mental health space? And I really want us to go, because DC's mental health space is currently going through some transformation, isn't it? The system transformation, I think it's been on now for 2 years, if I'm not mistaken, or more.
Yeah.
What are some of the issues that you are seeing that are plaguing the community that you would like to address?
Well, so I think that we need to make sure that services are easily accessible, that they are high quality, and that they meet the community where the community is. And so when I talk about accessibility, that's primarily making sure that services are located in the communities where people live, or that services are delivered in their homes or other places that are convenient for them to get to. That's also making sure that for whatever insurance they might have. There are providers that are open for new people to receive services. And then we talk about timeliness. And so that's making sure that people can get easy appointments if they need to go through an assessment process, or if they need to schedule a meeting with a counselor, or if they need to update their medication, that they can get access to that in a quick way. When I think about quality, that's making sure that we are delivering on what the healthcare system tends to think of as its three main goals, which are to make sure that people have a good experience, to make sure that the clinical measures of their wellness are moving in the right direction, and making sure that we do that in an efficient way and don't make that more expensive than it needs to be. And then I talked a little bit about just making sure that, again, those services are available in the places where people are. And I think the district is fortunate that there are a lot of organizations that provide these services, and that they are spread all across the district. And so people can find organizations that are close. But the other piece is making sure that there's a cultural fit. And so particularly while we're in Minority Mental Health Awareness Month, we want to make sure that organizations have staff that understand the different cultures that exist in the District of Columbia, that they're humble about their own cultural knowledge and assumptions, and that they engage people, including in the languages that those people would prefer to receive services if English isn't the easiest language for them. So there's a lot of work to be done.
So Mark, again, you touched on something which is quite crucial at this stage, because you realize that the District of Columbia has kind of, I would say, a balanced distribution in terms of population. You have, I think, 49 Caucasian, and then the other one, maybe 49 equally Black, minority, whatever that is, isn't it? But I don't see the same thing when it comes to the mental health space. So you get into the room, 3/4 or more of the population is of people who are in the mental health space are Blacks. 3/4 or more of the staff are actually African immigrants, okay? And 3/4 or more, again, you could say that within the administration itself is mixed. Why is it? What explains for this? Is it that the mental health space has been carved out to be something that is reserved for minorities, or what is the issue?
That's a good question. And I think that part of that has to do with the way that we fund these services. The Medicaid program pays for a lot of the services for people with mental illness and substance use disorders. And in the District of Columbia, people in the Medicaid program are overwhelmingly Black or Hispanic. And so some of that just has to do with who has Medicaid. And of course, that does mean that there are people who are white who have private payment options, and they're treated elsewhere. They're not part of the Medicaid system. And so the room looks different if you're in a Medicaid provider's services versus if you're not. But for people who are at the sickest end of the spectrum, they often end up receiving Medicaid. And so that's part of it. It's how we pay for these services. I think when you talk about the workforce, it's really remarkable to see the number of people who've come into the workforce, like you mentioned, who are African immigrants and immigrants in general. There's also a large segment of the workforce that's from Spanish-speaking countries, and so that's a really good sign that we're providing opportunities for employment, that we're providing opportunities for people who have at least some cultural affinity with Native district residents to be in the same space. But of course, there are nuances there too, and we know that the experience of African Americans and the experiences of African immigrants aren't always the same the same for Hispanic immigrants versus people who may be Hispanic in ethnicity, but who are native to the United States and to DC. And then at the administrative level, I think we see the same thing that we see in every part of the economy, which is combinations of structural racism and privilege, along with opportunities that are based on educational attainment, and just disproportionately people with graduate degrees that are required to take some of those roles historically have been people who are white. And so we're working to support getting more people in the pipeline who come from the community, and working to make sure that that people who are Black, people who are Hispanic, are able to be successful in taking licensing exams, and that we'll hopefully see them promoted as we move towards having more of them in the workforce to begin with, and they will increasingly take on those leadership roles. But for now, you're right, it's still not reflective of the way the district's overall population is mixed.
If you're just joining us, you're welcome, Lamboms Show. And tonight I'm speaking with Mark Levota, the Executive Director of the DC Behavioral Health Association. And our topic for tonight is navigating the mental health space in DC. Now, Mark, there's some other interesting thing which I've noticed. If you cross border lines both ways, the system is not the same. You go to Maryland, it's a completely different thing that is happening there. You go to Virginia, it's a different thing. The district seems to enjoy a certain privilege with respect to mental health, maybe, and other benefits. Why? What's going on there?
You're right that every state has its own approach to these issues. I think there are strengths and weaknesses on both sides of the borderline. In the district, we see a lot of use of paraprofessionals and providing supportive resources to people so that they're able to build skills and try to find ways to be successful managing their mental illness. In Maryland and Virginia, we see more of a focus on counseling and psychotherapy. And so I think primarily it's a difference in terms of approach. And then that also has an impact in terms of how easy it is for people to access care. In the district, we are fortunate that we bring the services to people. We deliver care in their homes, we deliver care in libraries, we deliver care wherever in the community it makes the best sense to help meet people's needs. In Maryland and Virginia, a lot more of the services are four-wall services. People have to go to an office, they have to meet a counselor, and they're going to spend the time in a more institutionalized setting. Not anything that's scary, but just formal in a way that the district isn't. And so that's a major difference that again has something to do with the way that we pay for these services, where the district has invested a lot more resources in making sure that people are able to get the support that they need in the community.
And since you're talking about the way it is paid, it's a Medicaid program. So let's talk about the system transformation. What is behind these transformations? Because again, the most recent one that is coming down is with the transition to MCOs, isn't it? Managed care organizations. And it seems to be, I don't know what is the reason behind that, and what are you anticipating? It seems as if many agencies are going to fold up when the MCOs really take over.
Yeah, so managed care is a way that state Medicaid programs try to make sure that costs are managed and that quality is managed. And the process for doing that is putting insurance companies between the government and the service providers. And the insurance companies then take responsibility for paying for care and for monitoring the quality of the care. In the district, for a long time, we have used managed care for physical health, for medical and surgical services. And so district residents are often familiar, and Medicaid beneficiaries specifically are familiar with our MCOs, AmeriHealth and MedStar and Care First, for their medical and their surgical care. And now the district is proposing to move mental health and substance use services into managed care as well. The idea is that this will make a more integrated approach to care, and providing a more integrated approach to care where medical needs and behavioral health needs are organized within the same organization, theoretically should mean that we will help to address what we know are disparities in care sometimes when those things are not pulled together. And so we do see that sometimes people get good mental health care, but they lose track of their physical health needs. Or they might have a good primary care doctor, but they don't get all of the substance use support that they need. And so the idea is that these managed care plans will bring that together. And both from a payment perspective and from a care coordination perspective, they will try to make sure that people get all of the physical and behavioral health care that they need. You're right, too, that it's going to be challenging. The services that are not in managed care right now are often working with people who have complex needs. They might have more severe mental illness. They might have both a mental illness and a substance use disorder. And so we are going to have to be really thoughtful as we move through this process to make sure that there's good monitoring, both of the managed care organizations as well as provider organizations, so that people will actually get all of that care that they need and not get lost while we're changing which insurance plan is paying which provider organization to provide which kinds of care.
Already, the business models for most agencies would have to change, isn't it? Because again, already people who are dealing with managed care organizations know the experience is quite challenging dealing with payments, isn't it? They're not as timely as maybe DHCF has been, and more rigorous, more. So again, it's either agencies will have to come up with, will have to be creative in the way they manage it. I don't know, what advice would you have to agencies that are currently looking at business models to structure them in order to meet this need?
Yeah, we're talking a lot to the provider network to make sure that they get ready for these changes. And we're talking to DBH and DHCF. Part of this is that organizations have to be paid adequately. And so there is a rate study that the Public Consulting Group has been contracted to do. And that's the first time that we're updating payment rates for these services since 2019. And the 2019 rates were set based on 2016 costs. So as anyone listening can imagine, the expenses are overwhelming relative to what organizations are being paid, and that needs to get fixed. The rates need to get updated, and then they need to get updated annually instead of having us wait these large gaps of time between updates. So that's part of the process, is modernizing our rate setting process and making sure that organizations can be paid for the work that they need to do. I think, too, the expectations are going to be higher. And so organizations, in exchange for getting paid better to do this work, are going to be asked to do new things. They're going to have to run their own electronic health records if they don't do that already. They're going to have to make good use of health information exchange technology that lets them learn about where other providers are seeing people that they're serving. And they're going to have to do more aggressive thinking and maybe even partnering with organizations that do things that they don't. Or they're going to have to build that capacity on their own so that people can get access to that full mix of physical health, mental health, and substance use treatment that they might need.
So Jane says, very important topic. It sounds to me like in the DC area, the care actually following people and meeting them at their point of need. It doesn't sound like most patients are willing to make the move. How long can the district do this without the willingness or the effort of those in need?
It's an interesting question, and for any treatment to be successful, and I'm not a clinician, but based on everything clinicians have ever told me in the 17 years I've been in this business and listening to district residents talk about these issues, if people aren't willing to participate, then the treatment won't be effective. That's first and foremost the truth of the matter. Mandated treatment programs fail, both for mental health and for substance use disorders. But when people are willing to participate in treatment, it can be very highly effective. And so that is something that's really important. I think the district does something special by making sure that we make it easy for people to get to that care, and sometimes by bringing that care to them, if that's the best way to get them the care. But ultimately, yeah, it requires people to participate and to be willing to make the steps that can help them reach their goals. That might mean changing some of their behaviors.
So that's interesting, Mark, because again, you realize that within the community, we talked again about that mix, and because it's a Medicaid funded program, so probably that is one of the reasons why you don't have many African immigrants within the programs, isn't it? It's a Medicaid program, and besides just being a Medicaid funded program, there is something within the African community, the stigma and all the secrecy. Many people do not want to be identified as having mental health challenges. Is there something that could be done within that? I'm talking about, because again, you have people who own agencies, African immigrants. Most of the community support workers are African immigrants, but then you don't see the number of African immigrants within the program that are call them consumers. That's the term being used here. But we know there's a deep problem within our African community, within our African immigrant community, that many of them have these mental health challenges and they're not able to. Is there anything your organization is doing or could do in order to take care of that?
Yeah, so I think that one of the pieces here is to make sure that people are aware that you don't have to have Medicaid to get access to these services. And the district does have sliding scale programs. There are what the Department of Behavioral Health calls local dollar payment options, where the District of Columbia makes payments directly that don't involve the federal government. And so those resources are available if payment is the barrier. In terms of privacy, I think it is also important for people to know that they can always opt out of having information shared, and it's within your rights to decide how your health information is shared. We certainly encourage people to allow treatment providers to share information with one another so that people don't have to repeat stories of hardship, so that people don't have to, just provide the same information over and over and over again. But if there are real concerns about privacy, then those are important things to talk to with therapists, and people have legal rights to have their privacy respected. So that's a second important piece. The third piece, I think, then is really just making sure that people are aware, like you were saying, that there are people who look like them who deliver this care, and that know their community, that know the particular cultural patterns that make it easier or harder to talk about these kinds of issues, and within the therapeutic context are then able to make suggestions about, here's how you could talk to your family about these issues, here's how you can talk to your friends about these issues. And the stigma issue is complicated, right? There are people who may have the belief that some kind of moral failing is involved in having an illness. And so we have to be clear about the fact that a mental illness is exactly that. It's an illness. A substance use disorder is something that has a biological basis and a chemical basis that means that people don't have the same responsibility, because you can only choose from the things that you're free to choose from. And so I think that there's a lot of work to be done in addressing that it's not a moral failing to have these experiences, but it's also not a moral failing to ask for help. And sometimes that's where the cultural barrier is people having the impression of, oh, I should not talk to anyone about this because that's not what's done. Or I only solve these issues by talking to faith leaders, and I don't want to talk to a healthcare professional. And I think those are complementary routes. I think that there are things that our cultural leaders, our faith leaders can be very supportive and often are. And then there's something different that healthcare professionals do to help people manage illness and disease.
So I agree with you to a large extent, but I'll take a leaf from the HIV pandemic, which again ravaged, call it Africa. But part of the reason was because of the secrecy. People did not feel comfortable. And I know within the community that, that aspect of respecting people's privacy, it's a difficult concept. People have complained about, you see somebody has gone to a hospital and has been tested there and is positive, and then you start hearing the story out in the neighborhood, isn't it? It becomes a challenge. And I think just many people will feel maybe comfortable talking to somebody who is non-African about this thing, because again, where we come from, mental illness is considered there's some witchcraft attached to it. There's so many different parameters. But I think, like you said, it's something to address within the community itself. We need to start talking about these things in a way that people are able to see that they have this access. People are aware that we work within this field. We should be able to assure our friends. But having been around, when it comes to something like substance use disorder, people are in denial. They just do not want to accept the fact that there's a problem, and how to overcome that is a problem. But let's move to something, Mark, that I really wanted to bring to your attention. Maybe two. One is the acute shortage of psychiatrists within the district. And yet there's an insistence for the medical director to be a psychiatrist. And I noticed that there's an uptick again within my African community. There are many people who are becoming nurse practitioners. What is wrong with having a nurse practitioner serve as a medical director?
Yeah, good questions, and I agree. We see in the federal Medicaid program that for outpatient behavioral health clinics, which in the District of Columbia are designated as freestanding mental health clinics, a medical doctor, psychiatrist has to be the director of the clinic. And the district is bound by those federal rules. I find that very restrictive and somewhat antiquated in terms of approach. That set of rules was developed in I believe the mid-1970s, when many people with serious mental illness were just leaving from long-term and expected lifetime hospitalization for those illnesses. And this is still a lag in federal policy catching up to the best medicine and the most successful ways to help the workforce evolve. So there's definitely work to be done on that front for the federal policy, and our partners at the National Council for Mental Wellbeing agree. And you're perfectly right to note that nurse practitioners with psychiatry specialized training are a great addition to the workforce to help address the psychiatry shortage and to make sure that there are people who can prescribe medication and make medication adjustments for people with psychiatric illnesses. I think that's a huge next step in improving how we organize care. The other work that is being done is trying to help psychiatrists have more time outside of one-on-one encounters that they can support primary care physicians to be the prescribers. And we are working on changes to DC Medicaid policy that will allow those structures to be set up, called collaborative care codes, and building more models for psychiatric consultation that doesn't require the psychiatrist to have a one-on-one relationship with every person who receives medication. And instead they could go to their primary care doctor, who would be in touch with that psychiatrist to make sure that the medication was appropriate for that person's psychiatric needs. But it's a real tough challenge, and the district actually has more psychiatrists per capita than the rest of the country, but maybe not in community mental health, unfortunately. So we still have to work to address those issues.
Yeah, that is news to me that the district has more psychiatrists. I find that interesting because I think, I'll tell you that I think so far as I know, there are only about 2 or 3 Cameroonians who are psychiatrists within the district, and then maybe say 5 to 10 Nigerians. I don't know any other outside Cameroon and Nigeria, and maybe that's just because I'm limited also because the experience I have is within the core service agency space. So, and we keep looking for psychiatrists. Nobody wants to get involved in that. But the other part, a step below that, is with licensed independent clinical social workers, isn't it? Because for some time it was difficult getting LICSWs, and as I think it still is, But what is shocking to me is that the best social work school, I'm not celebrating Catholic University here, but you also have Howard University. The same thing with psychiatry. You have 3 good universities around. University of Maryland too. What is the problem, and what is the organization doing in order to help out with the shortage of this licensed clinical staff?
Yeah, I mean, you're right to talk about the very high quality training programs that we have regionally. There are great social work programs, there are great counseling programs, there are great psychiatry programs, but we just don't train nearly enough people to fully meet the need. And they have a lot of options where they can work. And so we don't just find people competing for jobs within the core service agencies or in community mental health. They can get jobs at hospitals. They can get jobs with insurance companies and managed care organizations. They can get jobs in policymaking roles with local and national government. And they can work in Maryland and Virginia. And so we really have to keep working to build the pipeline, but we also have to attract people to doing community-based care. I think that starts early. I'm certainly encouraging psychiatry training programs to have people do rotations in the community, so they don't just learn what psychiatry looks like in a hospital setting, but they also learn what it looks like in a core service agency or some other community-based setting. We are talking again about rates and reimbursement, making sure that we can pay competitive salaries in community behavioral health so that people will consider staying in the community and not going into those insurance and administrative roles. And the district also needs to work to make it easier to get a license. We see people who have licenses in Maryland and Virginia have a very hard time getting license endorsement in the District of Columbia. And so I am certainly working very hard and with colleagues from just about every healthcare association in the district to encourage DC government to partner more closely with Maryland and Virginia to find a path to license reciprocity, so that we can make it easier for people to practice in the setting that is the best opportunity for them, which we think is in Washington, D.C.
So again, let's circle back to consumers. One of the challenges we have had, and I thought it was addressed, but consumers hopping from one agency to the other. It has been a big challenge, isn't it? You have one today, by the time you realize it, the consumer has switched to another agency, and they keep doing that. There's a recent memo. I mean, the DBH tried, and within 1 month, the whole thing was down. What is the solution to that problem?
Yeah, that's a magic question. And I think we are really working to figure out what the good solutions are here. Some of it is self-policing. Organizations that do this work need to be willing to say, you know, we're not going to hire people who are just moving a whole group of the people that they serve right along with them. And that's hard, right? People do get attached to, I know who my community support worker is. I want to be where they are, or I know who my counselor is. I want to be where. And so I think that, you know, it's got to be a balancing act of making sure that people understand that it's a whole organization that provides their care. And so you may follow your community support worker, but you may lose your psychiatrist and your counselor. And so people really need to understand the consequences of the decision that they might be making if they're going to move when a staff member moves. I think the other thing that we are going to have to work on is making sure that we just encourage that whole person care, because I think sometimes people don't feel like they're getting cared for by an organization. They do feel like they're only getting care from one person or the other, and that's negative. And then the third thing that people need to be aware of and worried about is that some organizations are making promises that they can't keep. And we hear that organizations are telling people that they can find them housing. And I mean, if I didn't have a home, I'd be looking for whoever was going to tell me they could find me housing. But if I lose my psychiatrist and I lose my counselor and my community support worker can't actually get me housing, then I'm in much worse shape now than I was at the beginning. And so I think people do need to be aware that some people are making promises that they can't keep. And I think some of that's well-intentioned, and people, you know, are really doing their best and they want to try. And if people feel like they haven't gotten what they needed, then they're going to shop. And they should. You know, if you have a mental illness or a substance use disorder and treatment is not working for you, go find someone else that will provide you treatment that works for you. Absolutely, right? And it's just a matter then of be cautious about people making promises they can't keep.
You touched on something which is very, chronic within the district. I mean, it may not be, it's a national problem, and that's homelessness. And somehow it has been tied into the mental health space so that people come into it with the expectation that we are going to have housing. And so agencies start tying up services, and the first thing they're promising you is, come with me, then we're going to give you a house. I mean, how do we decouple that? I believe that one way of solving that problem is by taking out that, call it the ability to provide the voucher system that DBH also has. Leave it to the housing and urban development. Let it stay there. And everybody who needs a house within the mental health space can go to HUD and get that. But within the district, you have that ability to have housing DBH is able to serve you in a certain fashion. What is the solution? How do we tackle the homelessness challenge in the district?
Yeah, well, DBH also shouldn't be making promises that they can't keep. And so that's been a real challenge for them. Their vouchers can't keep up with the need, even for people with serious mental illness or severe substance use disorders, who we know need both financial support and clinical support to stay safely housed in the community. And so DBH is going to have to rethink their approach, both to the voucher process and to the community residential facilities and recovery housing services, and make a way for people with serious mental illness or with substance use disorders to get into that housing, to stay in that housing. But at the same time, you're absolutely right. behavioral health services are healthcare services, and don't come with any promise of housing, and that's been a real challenge to try to figure out how to then get the people who do make housing support services available in the district able to prioritize people with serious mental illness and substance use disorders. And so that's the balancing act that we're going to have to rebalance again in the district. I mentioned earlier when, in the mid 70s, people were leaving the hospital, right? Hospitals used to be housing for people with serious mental illness. They came to the community. They might still be connected to a community mental health center. They weren't connected to housing anymore. And so you see a large increase in homelessness among people with serious mental illness. You see a large increase in incarceration. People end up in jail, and jail becomes where people are housed when they have a serious mental illness. And so that's not what we should have done to replace the hospitals, but we still haven't come up with a full or adequate replacement solution. And that's a project for the years ahead.
Now you mentioned some other thing about substance use disorder. Let's move away from the mental health directly and talk about substance use. Because it seems the district is doing so well with the MHRS, but SUD programs seem to be in real problems. I don't think they are well known. They're not well funded. They too have problems of payment, isn't it? What should be done? What can the district do or should be doing in order to shore up the SUD programs?
Yeah, the SUD programs, unfortunately, were not the highest priority when they were part of the Department of Health. And when they moved to the Department of Behavioral Health, when the Department of Behavioral Health combined the Department of Mental Health with what was then the Addiction Prevention and Recovery Administration in the Department of Health, we got the Department of Behavioral Health, they still stayed very siloed. And so, as you point out, the specialty mental health programs are kind of moving off in one direction, and sometimes the substance use treatment programs seem like they've been left behind. In part, that's about payment. It took a couple years to get those services reimbursable by Medicaid. The residential services have only been reimbursable through Medicaid for about a year and a half now. So those organizations are 15 years behind in terms of how they get paid. And they're also probably 6 years behind in terms of having their regulations set up in a way that match the expectations and parameters that professional addiction treatment specialists would recommend. So we need to provide technical assistance to those organizations as they continue to improve the quality of their care. The other thing that we have to do across the board, and especially in our substance use treatment organizations, is to make medication therapy a bigger part of treatment for people who would be best served when medication is part of their treatment. And historically, there have been some philosophical challenges. You talk about people giving up drugs, and then you give them drugs so that they can end their addiction. And so we have to unpack that a little bit and talk about medication and the difference between medication to help manage symptoms of withdrawal or to help alleviate the conditions associated with your physical well-being from the kinds of impact that chaotic drug use can have on people's lives. And so one of the ways that we do that is we have to measure it. And right now the district doesn't have good reporting on how many people with opioid use disorders are receiving opioid medication, or even how many people with alcohol use disorders are receiving alcohol treatment medication. And so I think that that's one of the critical pieces that we have to address. The other part is continuing to expand services that are at the outpatient level. We do have a strong availability in the residential treatment space, but we need to make options available for people whose need is not at the residential level of care. And that can include co-locating those services with mental health providers and co-locating those services with physical health primary care providers. And so I think we're going to have to continue to ask the mental health providers and the primary care providers to step up and be a bigger part of the outpatient substance use treatment space.
If you're just joining us, welcome to the Lamboms Show. And today on set with me is Mark Levota. Mark is the Executive Director of the DC Behavioral Health Association. Now, Mark, let's transition to something which is a critical piece of the problem in DC with mental health, and that is community support. It seems as if there's so much that is happening within that space. And I don't know how to put my hands around it, because it seems there was talk sometime about opening up the University of the District of Columbia to do some certification for community support workers, but that never took off. And now it's like a free for all. Anybody can become a community support worker, and we don't know what is happening. What is your take on community support, and how can what reforms need to be taken in that space?
Yeah, so I think that, what I'm hearing from some people at DBH and DHCF and what's been happening in a work group that was set up to involve some external stakeholders is redesigning community support and being more focused on specific activities that we want to see happen and treating those separately. And so there are at least three, there might be more, but there are at least three different activities that we need to distinguish. We need to set up a better way that we do clinical care coordination, which is about making sure that people are accessing, again, that full spectrum of medical and surgical, mental health, and substance use treatment that they might need. That's at the clinical level. We need to talk about non-clinical care coordination, and that might just be resource navigation. How do you get a new Social Security card? How do you renew your Medicaid? How do you get access to supplemental nutrition assistance programs? How do you, navigate through the metro system? Those kinds of skill building and connection to community resources activities. And then people need recovery support. We know that recovery is more successful when it is socially supported. And so this is an area where people with lived experience are often the best people to make connections with people and to offer them tips, really, on how it is that they address the challenges of living with those conditions. How do you manage that your medication might make you gain weight faster? How do you manage the cravings that you associate with going to a certain place or being around certain people who are still part of your life? How do you get a job when you know that you need to work second shift because your medication makes you drowsy in the morning? And so I think we're really going to have to do a better job of narrowly defining what we're asking in community support, and then asking for more consistent progress to continue to provide those services.
Great. So, Mark, let's get to your organization, and I want to focus the last bit of our conversations on your organization. I don't know how many members you have, but I realize that you don't have too many of the organizations owned by immigrants within the DCB. I don't know what the issue is. What is the challenge? First of all, how does an organization become a member of DCBHA?
Yeah, so organizations are welcome to join if they're providing mental illness or substance use treatment services to district residents. That's all there is to it. We have a sliding dues scale that's based on, those organizations' DC behavioral health budgets. And so small organizations can make small dues payments, and we expect larger organizations to make larger payments. And then they get all of those resources that we offer, as well as I mentioned, membership in the National Council for Mental Wellbeing. And so we hope that that's an attractive offering for organizations. We've got 35 member organizations, and they really are every size, from organizations that bill less than $500,000 a year to organizations that bill over $10 million annually. And again, that's just their DC-based behavioral health budgets. There are a couple of our members that are owned by African immigrants, and we're glad to have them be part of our membership. And we're happy to talk with others that are interested. And then it's just a matter of, do they see value in what they get out of membership? To sell my own process, I think there is really something valuable that we do to connect people to each other, and to make sure that senior behavioral health leaders are meeting each other, talking to each other, not just in government facilitated spaces, but where they can also talk about the business of behavioral health. And then, it's about organizations seeing that the work that we're doing around policy or around education or around community outreach match the things that they want to see the system moving in the direction of doing. And I don't know if we've made a misstep and there are policy recommendations that some of these organizations might not like. But I say to some of those organizations, well, if you join, you get a vote, right? And so I think that there's something that's just about how long have you been in the district? Do you even recognize that we're around? And I think that as organizations see me out doing the things that I do, and as they hear other organizations talk about their participation in the association, then I hope they get the impression that we're doing something that's valuable, and I hope that they can see eye to eye with us on the very high level that we all need to be working together to advance high quality whole person care for district residents.
I can tell you that one of the areas where you guys are feeling yourselves is you're not publicizing yourself enough. I mean, and I would suggest to you that maybe every time a new agency is certified within the district, let the certification office give them that there's an organization here that if you want to, you're free to belong to. Again, I think it's very important that we have a place like DCB is a great place. I was very happy that the pandemic led you guys open it up to everybody who could, even though you guys closed it back up so soon, even though the pandemic was not over. But it was great because there was a lot of work that was done. There were things that you were doing at that time that some of us got to see exactly firsthand. What is it on Tuesdays and on Fridays? You're able to see, it's not just, you are not just lost. But again, let me ask, many agencies are struggling. Call service agencies are struggling. Where do they turn to for help? You see because it's a business, many people treat it as a business, isn't it? So it's difficult to start saying best practices. And I just want to use one area. Take diagnostic assessments. So a consumer leaves one agency, they have just done a diagnostic assessment here, and is moving to a new agency, and they're expected to do another diagnostic assessment. And it could be a simple thing as just calling the other agency to say, hey, what is this person? And then we can look at it and based on what the person tells us. But you call an agency and they're going to give you the runaround just because we have not understood what that partnership does in order for this service to be delivered in a way that people are able to, enjoy and come out of the struggles they are making. What would be your suggestion to that?
Yeah, I think that on the issue of diagnostic and assessments, some of this responsibility does fall back to DBH and making sure that organizations are getting the information about transfers out. Because one of the things that I hear from a lot of our members is when someone's gone, then poof, they're gone. They don't know where they went. And so, I think that there is work to be done on that seamless transition and making sure that we do good handoffs in the case that people do make a choice that they want to receive services somewhere else. And then I think the other part of that is the new organization, the organization that's receiving that person into their system. They have to make a determination about whether or not they think the work that was done previously is enough or right. And so there probably is going to need to be some kind of update. Do you need to do a full diagnostic evaluation workup and a comprehensive assessment, those kinds of things? I think we can debate the merits of that. But should a clinician really get involved early on and say, like, do we have this right? Do we have the right diagnosis in place? Do we have the right plan of care? Are there resources that we're setting up for this individual to thrive? That's worth taking the time. And so I think we do have to make that demand, is if somebody said it's not working for me somewhere else, then wherever they show up, we got to make sure they get it right there.
So, I mean, maybe again, I agree with that, but look at it in terms of just what I'm really getting at is when you have these new agencies that come up, they should be supported so that they can survive, they can thrive. Because I believe one of the problems that the district has had, I mean, I've been within the system since 2012, when I started off at MBI, isn't it? At that time, nobody knew about community support that much, isn't it? Until then, look at the explosion within community support over how many years? It's just taken a whole life of its own over this period. And again, because it says a Medicaid funded program, there are many things that have happened. But I'm saying with this now, there should have been some best practices. There are things that, organize some little things to show organizations. Their technical assistance I've never had. So I'm asking, is there a possibility now of putting tips together? You are starting off, these are the things to pay attention to. Where do people go to when they need help in order to make this work, not just for the agencies, but also for the consumers? Because I think person-centered care, that's the framework around which this is built, isn't it? But where do agencies get that foundation? Where do they get the help in order to be able to execute these programs so that we don't find consumers running around all over the city?
Yeah, so one of the things that we made some recommendations, and I know that other organizations were asked to provide feedback as well, was work that DBH contracted in, I think, 2018 with MTM Services, which is a national consulting group in behavioral health, was to put together a user manual, essentially. And that manual, I have heard within the past few weeks, is going to be ready in a week or two. So, we're like 5 years late, but we're finally getting there. And whenever it comes out, from what I hear, I haven't seen it, but from what I hear, it's like a 300-page book. And so I think there is positive intent, and we have to assume positive intent sometimes, even in a vacuum. But it's really unfortunate that it's taken that long for that to be available. I also think, and this move to managed care might help in some respects. The MCOs are going to have some role in developing provider organizations that are part of their network. And so we do want to look to them for the expertise that they bring. And the Department of Healthcare Finance is going to have renewed interest in these issues because of their larger responsibility as a Medicaid payer and as the regulator for the managed care contracts. They have, over the past few years, invested a lot in building new technical assistance resources, and they've identified behavioral health organizations as eligible providers for that technical assistance. And so, I am certainly encouraging provider organizations to take advantage of some of the DHCF technical assistance. There's a project called the Integrated Care Technical Assistance Project, which is run by Health Management Associates. They are a nationally highly regarded organization that provides consulting for government entities, for managed care organizations, and for provider organizations. DC is paying for those services to be available for behavioral health providers for free over the course of the next couple of years. And they just didn't have very high uptake. I think 13 organizations are participating when we invited 83 organizations to apply. And so, you can take a horse to water, but you can't make them drink, right?
That's right. So,
and I think that the other piece of that, right, is like, again, from the first thing we said, when organizations are not struggling day to day with, can I pay my bills? Am I going to keep the doors open? Can I keep the lights on? Can I make payroll? When we get the rate set at a rate that you can actually do this work, then maybe you've got the staff that can take the time to do the technical assistance projects and really engage in robust and continuous quality improvement.
Great. Mark, I know I promised 1 hour, but just before we have just gone a minute over. The remainder of the time, maybe 2-3 minutes, I'd like you to identify, you said there are 3 areas in the policy space. What are 2 or 3 issues you are currently looking at in the policy space that you are monitoring DC Council or trying to push them to follow through?
Yeah, so the DC Council came up with some really good news for us on Tuesday. They completed the work that the mayor took some pretty significant initiative this year to provide grants for school behavioral health expansion to an additional 83 DC public and public charter schools. That means for the coming school year, every DC public and public charter school will have an opportunity to have one community-based organization clinician be part of their team. And that's been a 4-year project to get us to that place. And so I think both the DC Council and the mayor deserve a lot of credit. It's a multi-million, like over $10 million. This is a lot of money that they're pouring into this to make sure that our kids get the services and supports that they need. We are also, eagerly watching the end of the public health emergency and trying to make sure that people don't have too hard of a time getting their Medicaid or their Alliance benefits renewed now that we're going to move back into the renewal cycle. And so, we're asking the Health Committee of the DC Council to keep a close eye on that, as well as trusting the people at the Department of Healthcare Finance and the Department of Human Services that they're going to, do the best that they can while they meet their local and federal compliance requirements on those issues. Something else that happened recently in the budget process that I'm really hopeful for, even though I think it's just a start and we're going to need to do even more work, is that the mayor proposed adding about $6 million of additional spending to help people with what they're calling neurobehavioral conditions. And so this is expanding the treatment array for people with autism spectrum disorder and people with acquired brain injuries, which we normally think of as traumatic brain injuries or concussions, but also can include some other ways that people might experience a brain injury. We know for the serious mental illness population, over half of district residents with a serious mental illness have at least 1 and up to 6 concussions.
Wow.
So it's really important for us to be expanding care for those folks and making sure that we can do co-occurring care and address both their traumatic brain injury needs as well as their mental illness needs. And same for autism spectrum disorder. We know that there are a lot of, particularly kids, though we're seeing adults with autism spectrum disorder as well. But kids often need additional support when they have an autism spectrum disorder and a serious emotional disturbance. And so I'm really excited to see that we're finding a way to provide some additional support for those kids.
That was at the policy level. Let me take you to executive, and I really want to move away specifically to DBH because that is where we have. Are there any particular issues that you are looking forward to? What are the things that you are working on?
Yeah, I mean, so for DBH, DBH is going to have a really important role in this rate setting process and making sure that that methodology is going to work. We are talking to DBH about how we prepare provider organizations for DBH discontinuing the use of ICAMs and data WITs, which are the electronic health records that DBH currently provides. And some organizations, that's their only EHR. So we know that they're going to need money to buy an EHR. Mm-hmm. They're going to need technical assistance to configure it correctly, and they're going to need staff for information technology and data analysis. And so, a lot of work to be done on that, but hopefully, and this is the benefit, that means organizations will be able to do more of their own report management and make better use of health information exchange. So there's an upside. And similarly, something that we're hearing from DBH is that they are considering moving to mandatory accreditation for at least some services. And so again, DBH has got to come up with the money to make it affordable for provider organizations to do that. But when we talk about the quality of care in the network, and when we talk about making sure that people are managing to meet best practices, accreditation is a really good way for us to get some third-party confirmation, not based on the government's rules, not based on the provider's own maybe elevated self-opinion, but based on objective third-party standards. So we think that there's a way to do it right, and then we just have to get DBH to do it right.
Last piece, technical assistance. Is there anything you guys are currently working on? DCBHA, is there anything people have to look up to?
Well, like I said, we're really encouraging people to take advantage of what the district is paying for and making available for free. That Integrated Care DC project is a really important one. I just mentioned, as we move to providers operating their own electronic health records, we're going to ask DBH to put some block grant money in place to make some technical assistance available for that transition. Providers will need technical assistance with the work around accreditation. They'll need technical assistance around the move to managed care. We are also, really leaning on the expertise of the National Council for Mental Well-Being, and so sharing with our members, the things that the National Council has learned from other states moving to managed care for behavioral health services, and trying to help organizations get prepared for that change.
So if you're just joining us, unfortunately, we are rounding up this program. Thank you, Mark Levota. You've been listening to Mark Levota on the Lamboms Show. We are on every Monday, every Wednesday, and some Saturdays. But Mark is Executive Director of the DC Behavioral Health Association, and I want to sincerely thank you, Mark, for coming on. I'm trying to get a commitment that I can get to, even if it's just once a month for 30 minutes, just so that, because I think it's an important conversation. We have to move beyond what we get during our weekly meetings and start talking about this so that the population too can get aware, they can be aware of what is happening. Any last words, Mark?
Well, I hope that this has been helpful for anyone who's listening. Just a reminder that if you do need mental health support, it is available to you, and the Department of Behavioral Health Access Helpline is a resource if you just want to talk, or if you want to look for a connection to ongoing care. So mind your mental well-being, and tell somebody else about those resources if it's not for you, but if it's for someone that you care about. Really appreciate everyone in the community making sure that they help people get access to the care that they need.
So thank you very much. Again, if you are just joining us, you can follow this broadcast almost immediately on our Facebook page, on our YouTube, on our Instagram, and like, share, so that the conversation can go far and wide. And I think that we are going to have this shared within the provider network in some fashion. I think it's important for us to have these conversations. And Mark, once again, thank you. And I look forward to continuing this work with you so that we can improve on the services within the District of Columbia. Thank you all, ladies and gentlemen, and have a good evening.